The next area of testing that we're going to talk about is manual muscle testing. So we'll begin talking about manual muscle testing at the end of the first lab after we go through our goniometry. We'll do some demos of manual muscle testing. We'll talk a little bit about grading and documentation for manual muscle testing, and we'll get a little bit of practice. In the second lab, we will have more time to practice, and we will go through lots of different other types of strength testing, manual muscle testing, functional testing. We'll do some playing around with the dynamometer for grip strength, and our skills check for manual muscle testing will be in the third lab. So hopefully that'll give you a lot of time to practice. That having been said, I certainly don't expect you to be an expert on either goniometry or manual muscle testing by the end of this course, but this is your first introduction to it and your first chance to start practicing it. This is something that you will continue to practice and get better at throughout your career as a PTA. So it's another tool to put in your toolkit, another thing that you will be doing in the clinic. So what is manual muscle testing? It's a procedure that's used to evaluate the function and strength of individual muscles or muscles as a group based on performing a movement in relation to gravity and or manual resistance. So manual muscle testing, and we're going to abbreviate it MMT. It's an objective measure that is documented in the chart notes, the SOAP notes. It's used by a PT in an evaluation to identify weakness or pathology, and it's used in treatments to document progress or lack of progress. So in comparing goniometry and manual muscle testing, we are probably going to be doing goniometry measurements almost every time a patient comes in because you are going to see changes every time. With strength testing, we might not test strength every time they come in. You're not going to see, if someone comes in on Tuesday and then they're back again on Friday, you're probably not going to see a big change in strength between Tuesday and Friday. So it's going to be, a few weeks later that you retest strength. So it's not something that you're retesting all the time, but you do retest it several times throughout the person's course of therapy to document whether or not they're making progress. So in order to become skilled at performing manual muscle testing, you have to know all the things you learn in kinesiology. You have to know anatomy, origins, insertions, actions of muscles. You need palpation skills and observation skills. Those skills are all critical to proper assessment. So the skills that you started learning last quarter in kinesiology, we're bringing them forward into the next quarter, and then hopefully into the next quarter, the next quarter, the next quarter. So we're taking what we already know and we're adding on another layer. So muscles can be tested as a group, or you can set up an individual test position to emphasize an individual muscle. For example, testing the ankle inverters as a group, or tibialis anterior and tibialis posterior muscles separately. So frequently you're testing ankle inverters as a group, you're testing a particular joint motion rather than testing an individual muscle, but there are times when you might want to test an individual muscle. So there are a lot of factors that might affect strength and might affect the testing and limit your objectivity. So the first one is age. Would you expect a 25-year-old to have the same strength as a 70-year-old? Probably not. So that's going to affect things. However, you could have somebody who's got normal strength for their age, but you're not comparing them to another person. So that's what we mean by limit objectivity. There is an element of subjectivity to it. Gender's certainly going to affect that. Males tend to have bigger muscles and be stronger than women, even though we know there are a lot of strong women out there. But men have more testosterone, they build more muscle, and they tend to be bigger in stature. Muscle size makes a difference. Smaller muscles are going to test differently from larger muscles. So if I'm testing my grip strength, it's going to be different from testing hamstring strength. Smaller muscles, larger muscles. Fatigue could have a difference. If you just did a lot of exercise and strength training with someone and then you tested their muscle strength, they're probably going to test out a little lower than if you tested them before they retired. Or say this happens to me all the time. One of my joint replacement patients comes in and says, I am so tired. I didn't sleep at all last night, or I only slept for 2 hours. That's likely going to affect their strength. The amount of effort that the patient puts into the testing can also affect your results. So if the person is afraid to put a lot of meet a lot of pressure because they're injured, I mean that's legit, and they might not get as good of range. If they have pain, obviously they're not going to push into that pain. Malingering, that's a sore subject. Basically it's a way of saying the patient is trying to fake it for some reason. They have some kind of secondary gain to be not improving in their therapy. We'll probably talk a little bit more about that in your ethics class, but it's definitely a possibility. I like to attribute the best of intentions to people, and so my head doesn't go right there to malingering, but it does happen. Lack of communication, that's a big one. If you don't describe to the patient accurately what you're doing and what you expect from them, you might not get good results. Or if there's some other kind of communication issue. For example, you have someone who doesn't understand you because of a language barrier or a communication barrier. They have aphasia or some other, they have dementia. One time I worked with a young woman. She was an adult, but she was developmentally disabled, and she did not understand the testing. The way the PT first tried to explain it to her, it didn't make sense to her, and she didn't know that he would try to move her arm and she would just let him. So it was difficult to communicate what we were trying to do with the strength testing. And so he documented in the initial eval that he was unable to strength test due to lack of communication and unable to communicate the testing. In the next visit, her mother was present, and her mother was actually, I explained it to her mother. Her mother was able to explain it to her in a way that she understood, and we were able to do the strength testing. So sometimes those things can be overcome and sometimes they can't. So that's certainly something that might... we could, however, test somebody functionally. Manual muscle testing might not be appropriate for them, but functional strength testing could be appropriate. Consistent test positions, procedures, and the therapist, again, that's going to affect your consistency in testing your strength and the outcomes that you get. So as with anything, we're always going to talk about precautions and contraindications. There are times when you don't want to do manual muscle testing right after surgery, particularly if the doctor didn't know what he was doing, like in the cartoon there. But if somebody's got a lot of inflammation or pain, they're in a protected they're in a protection phase of an injury. They've got healing tissues, and you don't want to put stress on them. After abdominal surgery or hernia, because you don't want to put pressure on any sutures or anything, and the person might be kind of bearing down to do strength, and we don't want to affect that. If you're in an acute care setting in the hospital and you've got lines and tubes, last thing you want to do is pull any of those out, and manual muscle testing might not be the right thing to do in that setting. Again, you can do functional testing. There are other things you can do, but that's just something to consider. Cardiovascular conditions, that's a big deal. Somebody might perform what they call the Valsalva maneuver, and you'll talk about that in other classes as well, where they hold their breath against a closed glottis. It can cause your intrathoracic pressure to rise, and it can it can spike your blood pressure. It's a risk for cardiovascular accident or CVA or stroke. If someone has had an aneurysm or a myocardial infarction, they have a pacemaker, any kind of arrhythmias, emboli, hypertension, you just don't want to push them into a state of more risk. And so someone with those conditions, it might be contraindicated to do manual muscle testing. If they have a condition that there's risk of excessive fatigue, such as multiple sclerosis or Guillain-Barré, where testing the muscles, you might not leave them any energy for the rest of the day. And so, again, you might do more functional testing. That's sort of more of a precaution, because I certainly have had MS and GBS patients who I've done manual muscle testing with, but it's something to be aware of. There are different methods of muscle testing. I briefly alluded to it earlier. Manual muscle testing is sort of the conventional test. We call it brake resistance applied through a range while the muscle's actively contracting. Or you can do it with an isometric contraction, and that's what we're going to be learning to do in lab. The manual resistance versus a dynamometer or a biodex, which are machines that measure. Frequently we'll use a dynamometer for testing grip strength, because that's a good one to, you can quantify that grip strength pretty accurately. You can compare the two sides, and we will do that in lab. Biodex is a brand name of different machines that might do some strength testing. We are not going to do that so much in lab, but just know that that's something that's out there. A lot of times if you work in a like a human performance lab or a sports facility, that sort of thing, they might do more of the different type of testing. There's also functional strength testing. So there's a big difference between the strength to flex your hip and lift your leg up, and the strength to climb up the stairs. So with functional strength testing, we need to know is, okay, they've got the strength. Can they do the activities that they need to do? The thing that really comes to mind for me right now is a patient that I'm currently working with. She's post-surgical, post-back surgery, several months post-back surgery, but she is pretty restricted in her mobility. When you test her with manual muscle testing, her lower extremity strength tests out pretty normal. She has, good muscle contractions on all her lower extremity muscles, but she can't walk unsupported, and she doesn't have functional strength. So just because you have individual muscle strength, you might not have functional strength. And we haven't exactly teased out what the issue is with her. We're working a lot on balance and on safety, safe transfers and that sort of thing. But it's likely that it's a neurological involvement that's causing the problem. So even though she's got strength with manual muscle testing, she doesn't really have functional strength. So they're two different things. When we talk about manual muscle testing, we're going to use the brake test. It's most commonly seen in the clinic. It's convenient, it's versatile, it's fast, it's inexpensive in that you're carrying around the tools for it right now, your hands. So it's also, it's a nice quick screen. I mean, it's rare is the time when you're going to go in and test every muscle on somebody's body. A lot of times you're just testing one or maybe two motions, and it's very quick to just quickly screen someone and get some nice objective measurements. So in these pictures, it's just showing people doing some different manual muscle testing. So obviously in the picture on the left, the therapist is testing the person's hamstring strength or their knee flexion strength. It might not be the hamstrings individually, but certainly knee flexion, and shoulder flexion in the picture on the right. And both of them are against gravity. So we'll talk about against gravity versus gravity eliminated. So in terms of general procedures for manual muscle testing, we're basically, no matter what muscle we're testing, we're asking the person to hold their limb or their other body part at the end of its available range or at some other point in the range while we provide some manual resistance. So we want to make sure we place the position in a we place the patient in a supported position so they can concentrate on their effort of the part being tested. So if they're standing or sitting in a way that's unsupported and you push against them for resistance, you could, push them out of the position. So you want to make sure that they're supported. In the two pictures in the previous slide, in the first picture, the person is supported on the plinth as their hamstrings are tested. So bending that knee is not going to shift their position at all. You can stabilize the proximal joints. In the second picture, the person is seated and the therapist is stabilizing their other shoulder with their hand so they can test that shoulder flexion and, stabilizing the proximal areas of the body again. So initially, we're going to test an anti-gravity. That's going to be the first test, is do they have strength against gravity? If they don't have strength against gravity, then we change their position. We test them in the horizontal plane to eliminate gravity. And that whether or not they have strength against gravity, that gives us the first inkling as to the grade that they're going to get. So I talked a little bit about this when we were looking at the pictures. The area proximal to the area being tested should be stabilized in order to reduce compensatory movements. The resistance needs to be applied directly opposite to the line of pull of the muscles being tested. We're going to do a gradual pressure, not a sudden application of pressure. We're doing gradual, and most of the time we're using a long lever arm. Okay, and we'll be going over this in lab again as well. We're going to assess both sides just to provide a comparison, especially when one side is affected and the other isn't. So one thing, we're not testing against a standard of strength. I'm not testing my 70-year-old against my 20-year-old, but I'm testing them against their standard of strength. So they've got the unaffected side. What can we expect out of the affected side? So we want to test both sides. For the lab, this is how we're going to do it, basically. We want to provide our patient with a clear explanation of the procedure and the use of verbal cueing, like how we're going to tell them how to do things. So we're going to say, of course in lab it's going to be our classmates that we're testing and they know what we're going to do, but we are going to explain it to them like they don't know, like they're a patient. So I'm going to say, I want you to hold your arm in this position and don't let me move it. Okay, that's going to be my cue. Or you could say, well, lift your arm all the way up like this. Of course, you can't see me, but I'm doing shoulder flexion. And then I have them hold it in mid-range. I'm going to push on their arm and say, don't let me push your arm down. Okay, we're going to give them those cues. We want to provide adequate stabilization of the proximal areas of the body so we can avoid substitution motions. So for example, shoulder flexion, a substitution motion might be that they lean back, extend their spine to try to lift that arm up, and we're using basically the spinal extensor muscles to lift the arm up. So we want to have their spine stabilized so we don't get that substitution motion in there. So the first thing we're going to do, besides the explaining and the positioning, is a screen test. And the screen test, we're going to test active range of motion against gravity. We're going to palpate the muscle, making sure that muscle is the one that's working. We're going to observe active range of motion against gravity. Okay, so we'll talk more about grading, but if that person can move through their full active range of motion against gravity, they automatically get a 3 out of 5. That's the definition of 3 out of 5, and that's actually the most objective score that somebody can get, is they have at least a 3 out of 5. Okay, so if they can move through that full range of motion, active range of motion against gravity, they have at least a 3 out of 5, and then we're going to put some pressure on it to see if maybe they're a 4 out of 5 or a 5 out of 5, they can withstand more pressure. If a person can only move through a partial range, then we automatically place them in a gravity eliminated plane. And then we're going to be testing to whether they have less than 3. So whether they have fair or poor or trace strength. So if they can perform full active range of motion against gravity, then we apply resistance. If they can't, we don't apply resistance. We put them in a gravity eliminated plane. So we're going to be using the brake test method, like I said. So you're going to have your patient hold their position while you push in the opposite direction. You're going to cue them to get into the correct position, and then you're going to verbally cue them to hold it there and not let you push them in the opposite direction. So sometimes you can do different verbal cues, and we can try out different ones in lab. You can decide which ones you like the best. Most of the time what I say is I say, okay, hold your leg straight, don't let me push you down. Or hold your arm, don't let me push you down. Or some people will say, try to resist me. Some people will say, well, anyway, we'll talk about different cues. But mostly what I say is hold your arm there and don't let me push it down. Or don't let me move your leg, or something like that. So typically, we're going to test a 1-joint muscle in a short range. And a 2-joint muscle, we're going to be testing it in mid-range. So if you think about an individual 2-joint muscle, like your biceps, for example, probably if we test it at full elbow flexion, it's going to be not as strong as if we test it in mid-range at about 90 degrees of elbow flexion. If we test it in full elbow extension, it's probably not going to be as strong too. So those 2-joint muscles, we're testing them in the strongest area of their range of motion. So we want to apply force in the appropriate position on the limb, perpendicular to the segment and in the proper direction, meaning opposite to the line of pull of that muscle. We want to apply force with a comfortable hand position, or a lumbrical grip, where our fingers are flat against their hands, so we're not digging into them. It's not uncomfortable because of the grip we have on them. We want to build up pressure gradually, not have sudden pressure. We want to palpate the muscle being tested, and or observe the contraction, and you want to see that muscle contract or flicker. Sometimes if somebody's got a less than 3 or just barely 3 anti-gravity strength, the muscle will sort of quiver or flicker a little bit. And sometimes if they don't have any movement, they can't actually elicit a movement, you'll see some flickering, and then they have a trace strength, or a 1. We're going to accurately record that muscle grade, and we're going to identify possible substitution movements. Like I was saying with shoulder flexion, the possible substitution might be that you extend your spine to try to get that arm up higher. We're going to test if they don't pass the screen test, meaning they can't go through full active range of motion against gravity. We are going to put them in a gravity eliminated position, and we're going to test in that position. So while we're in lab, we will try different variations of positions against gravity and gravity eliminated positions, and we'll see what we can do. A lot of times the gravity eliminated positions tend to be either supine or side lying, depending on what the muscle is. So I just briefly talked a little bit about grading of manual muscle testing, and the grade is the objective measure that goes in the chart, and it's used to determine their diagnosis. The PT uses that when they do their initial eval. Their physical therapy their medical diagnosis might be status post-back surgery, and their physical therapy diagnosis might be lower extremity weakness and impaired mobility, something like that. And we're going to also use the manual muscle grade to assess progress over time. So objective observation includes determining the patient's ability to hold the test position, to move through a full range of motion or to overcome gravity. So that's all objective. It seems sometimes people say, well, isn't it subjective because it's your judgment of how much pressure they can hold? But it's, well, whether or not they can do full active range of motion against gravity, that's objective. And observing their whether or not they can hold the test position and whether or not they can overcome gravity, that's all objective. So I was said first, if they cannot move through the full range, if they can move through their full range of motion against gravity, it's a 3, which is sort of traditionally they use terms 0, trace, poor, fair, good, or normal, and it's more of the standard now to use the 0 through 5 scale. So 0 is 0, 1 is trace, 2 is poor, 3 is fair, 4 is good, and 5 is normal. And then there's some pluses and minuses. We'll talk a little bit about that too. So if the patient can move their body part through the full range of motion against gravity and hold the body part in the test position, meaning, like example, shoulder flexion, you move actively against gravity through the full range of motion, and you can hold that arm out against gravity, they get a 3. And that is the most objective observation made during testing, because gravity is gravity and it stays the same. It's a constant. So if they can't, they can move the body part through the complete, they can't do it against gravity, but they can move it through a full range of motion in the horizontal plane. In other words, gravity eliminated, that's a 2. So it's poor grade. They can move through the full range of motion by themselves, but they can't do it against gravity. That's a 2. Okay, and so that's pretty objective as well. Trace, or grade 1, is given when there's no visible movement through a part's range of motion, but you can palpate a slight contraction in the muscle. So you're palpating at the musculotendinous junction or the belly of the muscle. They try to move and can't, but you feel a little quivering there. So that's a trace. No evidence of even a slight contraction, absolutely no movement, that is a grade of 0. So 0 is 0. You don't feel anything, you don't see anything. Okay, if they can move through, you do your screen test and they can move actively through the full range of motion, they have at least a 3. Then we're going to test them with additional pressure to see if maybe they're a 4 or a 5. So grades, so 3 is fair. Grades above fair are assessed with the body part in the test position with additional pressure applied by the therapist. So a grade of good or 4, that says that the patient can hold the body part in the test position against moderate pressure. So the difference between a 3 and a 4, I'll say, they can hold it against gravity, but as soon as you apply any pressure, they can't hold it. That's the difference between a 3 and a 4. If you can apply some pressure and they can hold it, it's a 4 and possibly a 5. The difference between a 4 and a 5 is, you say, well, moderate pressure, strong pressure, what do you mean by that? But a 5, you're putting pressure, they're meeting your pressure, they can hold the test position against, we'll test it in lab, but against strong pressure. Grade of 4, they can hold some pressure, but maybe not, the most pressure you can put on it. And obviously, the amount of pressure you put on something is going to change depending on what body part it is, how big the muscle is. Sometimes if you're testing big muscles like hamstrings and quads and stuff like that, it takes some strength for you to do it. If you're testing, I'm trying to think of a small muscle, wrist extension, for example, it doesn't take a lot of pressure to do that, but you can tell if they can hold the test position or not. So you can add plus or minus to grades 0 through 5, although I rarely have seen a 0 plus. I don't know what that means, but anyway, you can add plus or minus to further describe muscle ability. Some people don't like the plus or minus because it introduces more subjectivity to the grading, but sometimes a plus or minus grade gives you some important information. For example, the example given here, a patient with a fair grade of a 3 might not be able to use an orthosis effectively, but the patient that has a fair plus, so they can withstand a little resistance against gravity, they might be able to tolerate the additional weight of an orthosis. But if they can't withstand any kind of resistance besides gravity, then they might not be able to use that orthosis effectively. So it's a fine line, but functionally it really makes a big difference. So sometimes you want to document that, because you want to say, well, they have anti-gravity strength, but they can't tolerate any more pressure. So the difference between a 3 and a 3 plus. Or if you put heavy shoes on someone, if all they have is anti-gravity strength and hip flexion, they won't be able to pick their feet up enough to walk effectively. But if they had a 3 plus, they might be able to do it. So I have descriptors, and in the module in Canvas, there's a chart, and then in the book, of course, with descriptions and functional descriptions of the scale. There is another scale that eliminates the pluses and minuses and uses 0 through 10. Again, like with the goniometry, you have to make sure that you know what the standard is for the facility where you work, and that you're maintaining that standard. So we have, at the hospital where I work, had meetings in the past where we all discussed the pros and cons of using different scales, and we agreed on a standard scale to use. So just to go through these quickly, normal, which is 5 out of 5, withstands strong pressure in the test position against gravity. Good plus is a 4 plus, withstands moderate to strong pressure. So probably if I put a 4 plus, it means, boy, they almost don't break when you press on them, but maybe just a smidge. Good is a 4, it withstands moderate pressure, but it breaks a little bit. 4 minus, between 3 plus and 4, so you can decide what you like with 4. We can look at some of the other scales and that have functional descriptions that might make a little more sense. Fair plus, 3 plus, it withstands slight pressure. 3 holds the test position against gravity, but you cannot put any additional pressure. So if you added an orthosis or any kind of weight on there, they wouldn't be able to do it. Fair minus, so they sag from the test position, or they only move through a partial range of motion against gravity. So maybe they can move through a complete range of motion in the horizontal plane with gravity eliminated, but maybe they can go through more than 50% of their range of motion against gravity. So not quite a 3, but a little better than a 2, right? So a 2 plus, they move through 50% of their motion or less in the anti-gravity position. Excuse me. So they can hold resistance in an anti-gravity position. So that's something, a 2, they can move through the complete range in a horizontal plane, but they can't tolerate any resistance. But a 2 plus, they can't go against gravity, but they can tolerate a little resistance in an anti-gravity position. So you can kind of see the difference between those two. 2 minus, they move through the partial range in a gravity eliminated or horizontal plane. And trace, slight contraction, there's no pluses and minuses on the trace in the 0. Trace is slight contraction, no visible movement. 0 is just nothing. Okay, so what we're going to do on the skill checks in lab, in the module there's a list of the muscles that you'll expected to be able to potentially test in. We'll practice these all in lab. What I want you to be able to do is I want you to be able to get the person in the position, in the starting anti-gravity position, and know that if they can't complete the full active range of motion in anti-gravity, you need to know how to position them in a gravity eliminated position. You need to know the proper way to stabilize them, how to do the screen test movement to test if they have at least a 3, how to palpate the muscles, identify any substitutions that they might do, where to put resistance, and the direction to put resistance. Okay, so again, just like goniometry, there are different positions to measure the same muscle action. So we're only going to be practicing one probably in the lab just for simplicity and to make sure we have enough time to cover everything. But sometimes you will encounter different techniques for positioning. Well, sometimes you're going to do functional tests in the clinic, and we'll look at a little bit of that in the lab. Let me just give you an example. There's the picture that we looked at earlier where the person was getting their hamstrings tested in the prone position. That's technically the anti-gravity position for knee flexion. You could do it in standing. They're a little less stabilized, but you're doing. You could do it in prone, where their trunk is completely stabilized. You could do it in standing. That's an anti-gravity position for the hamstrings. A lot of times when we're testing, for example, people after total knee replacement, we're testing knee extension and knee flexion. We have them do it in a seated position, seated on the edge of the mat table or the plinth, and it's a really quick screen. You push on their leg, you pull on their leg, and tell them, don't let me push you down, don't let me pull you up. You're testing the hamstrings on one and the quadriceps on the other. Although you're not testing against gravity for the hamstrings in that case, you're overcoming the lack of gravity by putting a little more strength into it. So there are other ways that we can test if there's some reason why you don't want to have the person switch positions a bunch of times. So it's a pretty quick way to screen things. It doesn't take very long to do manual muscle testing. If you were going to go and test every muscle in the body, that would take a long time, but usually it's super quick. I was just on Friday, I was testing someone. I was writing a doctor's note for them. I was testing their knee extension and knee flexion strength, and it was this quick. I said, okay, sit here on the edge of the table. I bent their knee. I said, okay, don't let me pull you up. Boom, there's hamstrings. Don't let me push you down. Boom, there's quads. And they had both ways. They had normal strength. So it's a super quick screen. However, just because somebody has a certain strength, that does not necessarily denote their ability to perform functional activities. Like the patient that I described earlier who had normal strength with muscle testing, but then didn't have normal mobility, so they didn't have the functional activities. So also, a normal muscle grade doesn't necessarily indicate a patient's ability to return to his or her normal level of activity. It talks specifically here about sports, but you're better off testing, especially sports participation and things like functional mobility, with functional tests, because like the example I gave with my patient who has normal muscle strength when you're doing muscle testing, but not a normal level of functional mobility. And so just because they have that manual muscle testing, that is just one piece of the puzzle. It doesn't necessarily denote how they're going to perform in functional activities. So then testing them functionally is the next thing to do. So just like with goniometry, the way to get better at manual muscle testing is to practice, practice, practice. Okay, I'll see you all in lab.